Okay, good evening, everyone who've joined us so far. I'd like to thank ESE for providing the platform for us to hold the webinar today. My name's Louise Breen, and I'm an advanced nurse practitioner in endocrinology in the UK, and the chair for the nurse committee for the Society for Endocrinology. And I'd like to welcome you all today. We're going to be about 1 hour in length for the webinar today. Please do ask questions throughout using the Q&A button, which you'll find at the bottom of your screen. We won't be monitoring the chat box, so please do use the Q&A box. The session is being recorded and will be available on the ESE website as soon as possible after the session has concluded today. I would like to welcome Professor Michael O'Reilly, who is a consultant endocrinologist at Beaumont Hospital in Dublin and clinical associate professor at the Royal College of Surgeons in Ireland. And I'm going to hand over to Michael now to do his presentation. Thank you.
Thank you, Louise, and thank you for the introduction that you gave me, and thank you to the European Society for the invitation to speak to this group today. So I'm just going to share my screen. And so as Louise mentioned, I'm an endocrinologist here in Dublin. I used to work in Birmingham with Sherwin, and I know many of you from my work with the Society for Endocrinology. So it's a pleasure to speak to you today. I'm going to give a kind of an overview of the management of PCOS and some considerations around long-term management, long-term health complications, some of the psychosocial aspects of the disease, and hopefully in your clinical practice, this will be of some use to you. So why is PCOS important? Well, it is very common. It affects about 10% of women of reproductive age, but actually in reality, it's probably more than this. And when I say reproductive age, I have to caveat that by saying that we're increasingly seeing health complications of PCOS throughout the female lifespan into the postmenopausal years when some metabolic health complications can manifest. There is an increased risk of type 2 diabetes in this condition, probably 2 to 3-fold higher. There is an increased risk of non-alcoholic fatty liver disease and an increased risk of cardiovascular disease. So in addition to some of the cosmetic things that patients present with and some of the fertility concerns, we do have this background metabolic risk and risk of other health complications, which has been neglected in the past or perhaps poorly understood. And it's interesting that evidence in PCOS until recently has been informed by low quality evidence. And the fact that the PCOS consensus guidelines, the first ones were only published in 2018, tells us a lot about where it's sat in terms of priority lists. There's been an update to the 2018 guidelines recently in the form of a 2023 update by essentially the same team, where they have updated clinical guidance based on new publications and studies over that time period. There are numerous ways that we can diagnose PCOS, and by far the most common criteria are the Rotterdam criteria. So up until 2003, we used to use the NIH criteria, but in 2003, the Rotterdam consensus criteria recommended that we added in polycystic ovarian morphology on ultrasound as one of the possible criteria to help diagnose this condition. To meet Rotterdam diagnostic criteria, a patient has to have a total of 2 out of 3 of the following clinical features. So oligo or amenorrhea. Oligoamenorrhea is defined by less 8 menstrual bleeds or less per year. Clinical or biochemical signs of androgen excess, so acne or hirsutism or an elevation of testosterone in the blood, and polycystic ovarian morphology on ultrasound. Now, in recent times, we know that from the latest guidelines, we can actually replace this finding of polycystic ovaries with measurement of a hormone called anti-Müllerian hormone, or AMH. And some of the work in the updated guideline in 2023 looked at the evidence behind doing that. So in other words, helping to avoid an invasive scan and replace it with a biomarker. And of course, we have to exclude non-PCOS pathology before we make a diagnosis. So if a patient has clinical signs and symptoms suspicious for Cushing's syndrome, then we should not be diagnosing them with PCOS. As you can see, there is significant clinical heterogeneity between the subtypes. So application of the Rotterdam criteria will generate 4 phenotypes. Most patients here have phenotype A, whereby they have androgen excess, oligomenorrhea, and polycystic ovarian morphology on ultrasound. But you can see in phenotypes B, C, and D, you can get subtypes without the imaging findings, without ovulatory dysfunction, or without androgen excess. And that's where the 2003 criteria differed from the NIH criteria. I've briefly mentioned anti-Müllerian hormone, or AMH, and this is made predominantly in ovarian granulosa cells. And if there is a large number of follicles in a PCOS ovary, then it stands to reason that anti-Müllerian hormone levels would be elevated. And that is indeed the case. And we know from a number of studies that we can help to diagnose PCOS by using this biomarker in place of ultrasound. But like any test, it is far from perfect and there are some limitations. So levels are elevated in women with PCOS, but you will have women with PCOS who do not have high AMH levels and they will overlap with normal women. Sometimes we pick up an AMH level of 50 or 60 in a 35-year-old woman, which would be considered to be threefold elevated above normal range, and they have otherwise no clinical features of PCOS. So it's important when we are making a diagnosis, if we're using AMH, that we factor all of this in. And I would encourage you just to familiarize yourself with the assay that AMH is measured on in your hospital or where it is sent out to and what the local cutoff levels are. PCOS is a heterogeneous condition, and as a result, there are divergent referral patterns to secondary and tertiary care. So many get referred to our colleagues in dermatology with cutaneous manifestations like acne and hirsutism. Traditionally, this condition was looked after by obstetricians and gynecologists who, by nature of their training, would have predominantly focused on the fertility and menstrual aspects, and perhaps had less of a focus on some of the metabolic complications. Obviously, endocrinology is increasingly involved and probably should be the central player in receiving these referrals. And then other physicians might receive referrals for weight management as well, because there is a 70% prevalence of overweight or obesity in this condition. This is an audit we did on our hospital presentations through the endocrinology clinic back in 2022, and we retrospectively followed or retrospectively reviewed indications for referral to our clinic. There's obviously significant overlap here, so these obviously won't add up to 100%, but the prevalence of ovulatory dysfunction was almost 80%. The prevalence of hirsutism and acne was very, very high. Hirsutism and acne are hallmark features of androgen excess. Alopecia is less common, but frequently reported by patients. And many patients increasingly report a condition called hidradenitis suppurativa, which is an inflammatory dermatological condition, typically affecting the axillae and the groin associated with androgen excess. So our clinical history taking and biochemical workup for patients with PCOS is important. You should document when their period started, i.e. menarche. Body mass index, blood pressure should be evaluated. Ferman-Galway score is a marker of hirsutism that I'll speak about shortly. Document any history of acne. You should examine the skin and the axillae and the nape of the neck. This patient here on the right-hand side has clinical signs of insulin resistance called acanthosis nigricans, and you might consider non-PCOS pathology if a lean patient had acanthosis nigricans. Gonadotropins and estradiol should be measured, and although the consensus guidelines only focus on measuring a serum testosterone level, we know from some of our published data that actually measuring other androgens like androstenedione and DHEAS can be very diagnostically helpful. Patients should have their LFTs measured. There is a high prevalence of non-alcoholic fatty liver disease. Glucose metabolism and homeostasis should be assessed with at a minimum a HbA1c, and if this is abnormal, the patient should have a fasting glucose plus or minus an oral glucose tolerance test. In those patients who are seeking fertility, they should have a day 21 progesterone and a hysterosalpingogram performed. Transvaginal ultrasound, I should probably remove from that slide. It's useful in certain situations. Many of you will be looking after younger patients who may be virgins, and obviously transvaginal ultrasound is not appropriate in a patient who is hymen intacta. So this is where transabdominal ultrasound is reasonable, or measurement of AMH. But if we measure AMH in a younger patient, we have to be cognizant of the fact that AMH levels do not peak in the blood until the mid-20s. So it is difficult to get a good evaluation of PCO morphology in adolescent patients. So how do we treat PCOS? Well, I've broken it down into some subcategories, and I've gone into some more detail in some of these areas. So for patients with irregular periods, metformin, which we typically associate with type 2 diabetes, is very effective. It's an insulin sensitizer, and it is very effective at restoring ovulation and restoring menstrual regularity. Lifestyle modification is really important, but the guidance that we give to our patients for weight loss is often very suboptimal. We don't have time in our clinical consultations to get into detailed conversations around diet and exercise, and we're all pushed for time in our clinics. So we need to do this a little bit better. The contraceptive pill I'll talk about in a while, and this is very effective for some patients, but it is contraindicated in other patients. We sometimes give cyclical progesterone to induce periods every sort of 3 to 4 months in patients who are amenorrheic, who may not be responding to metformin or lifestyle measures. I won't get into too much detail on subfertility related to PCOS today, but I've briefly mentioned metformin. Increasingly now we use a drug called letrozole, which is an aromatase inhibitor, and that is a very effective oral ovulation induction agent in PCOS. Some patients will need IVF, but not all. About 70% of patients will need some sort of assistance conceiving, but the proportion that go on to need IVF is much less than that. Hirsutism can be challenging to treat. We often recommend local measures like laser therapy and hair removal creams. Increasingly, patients will want systemic treatment for this. Oral contraceptive pills in the consensus guideline are the first recommended treatment, first-line therapy, but there will be some patients for reasons of BMI or other health risks who are not suitable for the combined pill. And in those patients, as long as they're not trying to conceive, we can recommend oral antiandrogens like spironolactone. This is just a reminder on the reproductive hormone changes throughout the menstrual cycle. So in the first part of the cycle, FSH increases. Towards the middle of the cycle, LH, you get an LH surge, which triggers ovulation. And you can see then when ovulation happens around day 14, the Graafian follicle changes into a structure called the corpus luteum. And the corpus luteum is responsible for progesterone production. That's denoted by the green line here. And if we want to check for ovulation, measurement of progesterone in the mid-luteal phase, so around day 21, is a very effective strategy to confirm ovulation. And then I mentioned the use of cyclical progesterone for patients who are oligo or amenorrheic in PCOS, and we try and mimic the reproductive cycle that I've shown on the graph by exposing them to progesterone for 7 days and stopping, and then the lining of the womb should break down and they will have a menstrual response. Hirsutism is measured using a clinical scoring system called the Ferriman-Galway score, and this is marked out of 36. It covers a total of 9 body areas, each graded from 1 to 4 according to severity. It's a bit of a cumbersome tool to use in the clinical environment, but we should do our best to utilize it. The problem with using it is that many patients will use hair removal approaches before they come to see the doctor. They might be embarrassed if they're coming to see the doctor or nurse to show evidence of hirsutism. So often they will remove it and it's not an accurate score on the day of the clinical consultation. So what's abnormal on a Ferman-Galway score? Well, again, this is quite subjective. Marks above 6 out of 36 would be consistent with hirsutism, but in certain ethnic populations, you could have scores that are higher and not necessarily be pathological. So, for example, in some South Asian women, a Ferman-Galway score of sort of 6 to 9 may not be pathological, whereas in Southeast Asian women, scores as low as 3 or 4 could actually be pathological. So there are ethnic variations to this, and there are different cutoffs depending on the ethnic population studied. So it's important to bear that in mind when we are assessing our patients. So it's usually recommended that local measures are used first to manage hirsutism. That could be waxing or plucking. A lot of women need to shave, and in severe cases, doing it on a daily basis can actually exacerbate the hirsutism. Laser therapy is recommended for dark hair, and electrolysis is recommended for women with lighter colored hair. If we're going to progress to systemic treatment with oral agents, first line is the combined oral contraceptive pill. And this has a couple of mechanisms whereby it might help with hirsutism. So estrogen in the pill helps to mop up testosterone by increasing sex hormone binding globulin, and that mops up free testosterone in the circulation. Some of the pills also have an anti-androgenic progestin in there, which additionally blocks the androgen receptor and can have an additional benefit. Anti-androgen therapies such as spironolactone should also be considered. This is actually very effective and very safe, but it should be in most cases given with contraception. So spironolactone has some teratogenic potential. In a male fetus, it risks feminization of the fetus, and we recommend stopping at 3 months before a patient tries to conceive. And if they're not trying to conceive, that they should really be on something like a progesterone-only pill or other contraception while they're on it. It's effective in about 80% of cases. Hair removal creams, fluornithine is an inhibitor of an enzyme called ornithine decarboxylase. It's actually, I find in my practice anecdotally, of limited benefit, and it can actually worsen acne in a lot of patients. For alopecia, anti-androgen treatment is also beneficial. That could be the combined pill. It could be spironolactone. And the same for acne, that will also respond to the same medications. The dermatologists sometimes prescribe minoxidil as well with the anti-androgen. But if any of you be uncomfortable with that in your clinical practice, I would consider a dermatology referral. So I think it's very important as a group of clinicians, whether doctors, nurses, or otherwise, that we're familiar with the combined pill, because these medications are prescribed extremely commonly in primary care, often very much so in secondary care, and they are not without risks. And it's important that we understand who should get them and who should not get them. So in PCOS, we should be asking ourselves, what are we trying to treat? How old is the patient? Are they overweight? What are their fertility plans? What is their metabolic risk? And what are the contraindications, whether relative or absolute, to prescription? And many patients with PCOS simply will not be suitable candidates for the combined pill, and it may be completely contraindicated. So what are the indications for combined pill use in PCOS? So it's very effective for oligo or amenorrhea because it will very effectively induce periods, albeit hormonally induced periods, but it will prevent endometrial hyperplasia by doing this. It is very effective treatment for some of the clinical features of hyperandrogenism, and about 70 to 80% of people will have benefit in terms of their hirsutism. It's obviously a very effective mode of contraception, and it can be useful to manage dysfunctional uterine bleeding. And although this is not a diagnostic criteria associated with PCOS, many patients with PCOS will get very painful, erratic, and chaotic menstrual bleeding, and the pill can rectify that in some of those patients. What type of preparations exist? So most preparations these days contain a synthetic form of estrogen called ethinyl estradiol. Typically, the dose in the pill would be somewhere between about 50 and 30 micrograms. Older pill preparations have higher doses. So Dianet, for example, has 35 micrograms of ethinyl estradiol, and that is increasingly discouraged because of risk factors around thrombosis and hypertension. These can be monophasic or multiphasic, and all that means is that monophasic is the same dose throughout the cycle, and you stop at 21 days, have a pill-free period, and then menstruation will start. There are multiphasic preparations where there are different doses. Drugs like Clara, which is available in some countries, have different doses of estrogen and progesterone at different times of the cycle. The progesterone component in the pill is very heterogeneous. Some are pro-androgenic, some are anti-androgenic. And although the latest PCOS guidelines doesn't mandate which one we should start, for most patients, the intuitive benefits will sit more with anti-androgenic progestins. So drugs like Yasmin-L and Yasmin, which contain the preparation drospirenone, are often favored in PCOS because they're anti-androgenic progestins. And then sometimes we tailor the regimen. So patients who have very painful periods might want to take a pill preparation continuously for 3 months and then take a break to have a bleed and then go again for 3 months so that they can avoid unpredictable bleeding. We know that this is a very effective treatment for androgen excess, and this is borne out in the studies. So it will suppress the estrogen component will suppress LH secretion from the pituitary, and that is a potent driver of testosterone production from the ovary. They will increase SHBG production at the level of the liver, and that helps to mop up free testosterone. The anti-androgenic progestins I've spoken about, and they will antagonize the androgen receptor. And although spironolactone is effective, the evidence compared to that available for the pill is significantly lower with spironolactone, but both probably in the region of about 70 to 80% for hirsutism. And you can see here the impact on circulating testosterone levels that the pill has. So it's not just a clinical benefit, but you'll also see a biochemical benefit in this meta-analysis. Any other health benefits of being on the combined pill? So cycle regulation and quality of life is important. Despite what we often hear, most studies demonstrate that there is an overall improvement in mental health, although some patients will report a destabilization with certain preparations, and it's almost impossible to predict this. There is a bit of evidence on the use of drugs like Yasmin or Yasmin-L for severe premenstrual disorder, and sometimes we prescribe that in patients who experience those severe luteal phase side effects. It helps with coexistent ovarian cysts. It's beneficial for endometriosis, and I've mentioned previously that it can help with heavy menstrual bleeding. And there is actually a reduced risk of certain cancers. So colorectal and ovarian cancer slightly reduce risk, and there's a really significant reduction in the risk of endometrial cancer. And that's very intuitive because it induces regular cyclical bleeding. And the biggest risk factor for endometrial hyperplasia and dysplasia, followed by carcinoma, is absent or infrequent bleeding, which lead to thickening of the lining of the womb. But it's not a perfect class of medications by any means, and there are relative and absolute contraindications that we should be aware of. Over the age of 35 and a BMI over 30, I am often a little bit hesitant to prescribe the pill in that group of patients. Migraine without aura is a relative contraindication. Lipid disturbances and patients who smoke, regardless of their age, it's a relative contraindication. Absolute contraindications should never really be prescribed for anybody over the age of 40. A smoker over the age of 35 should not get the pill. A BMI above 35, there's a much higher risk of hypertension and venous thrombosis. Established cardiovascular disease or cerebrovascular disease, patients who have just given birth because they're at high thrombotic risk, patients with a family history of a blood clotting disorder is kind of a borderline one, but if there is a personal history of a thrombophilia or a personal history of a thrombotic event, then I would not prescribe the combined pill in that person. The reason why the clotting risk is high with the pill is that it increases production of certain clotting factors at the level of the liver. And this is why HRT for most women does not increase the risk of blood clots, because it's often given in a transdermal approach. And even in those who take it in tablet form, where it is metabolized through the liver, those patients are given much, much lower doses of estrogen than a patient on a combined contraceptive. The risk of thromboembolism, we should be familiar with it. So most patients, if you follow 10,000 women for a year who were not prescribed any hormonal contraception, about 2 of those women would develop a blood clot. If we follow 10,000 women who are on the combined pill, somewhere between 3 and 5 per 10,000 of those women over a year will develop a blood clot. Sorry, apologies. The risk, it'll go between 6 and 10. So the risk is increased 3 to 5-fold. And the absolute the relative risk sounds a lot, but the absolute risk for most patients is actually relatively small. It's highest in the early months after starting, and it's probably higher with preparations like Yasmin and Yasmin-L. They're so-called 4th generation pills for unclear reasons. So you can see there in this table the relative risks. So in women not taking anything at all, followed for a year, 2 out of 10,000 will get it. And then it increases upwards to about 12 per 10,000 with certain preparations. The progesterone-only pill is a useful tool for some women with PCOS. So those who have a relative contraindication to combined estrogen and progesterone preparations, we can give them the progesterone-only pill. The most common preparations are Cerazette and Azalea, which contain desogestrel. There's another preparation called Noriday. This works by thinning out the lining of the womb. They usually don't have either anti-androgenic or pro-androgenic effects in a meaningful clinical way. The mechanism of their contraceptive action is that they cause thickening of cervical mucus. Some of them will suppress ovulation, and they will thin out the endometrium. So the ideal menstrual response is really what we want to see is amenorrhea in these patients. And it's a healthy way to induce absent periods, keeps the lining of the womb nice and thin. And it can be effectively combined with metformin and particularly spironolactone for other health benefits in PCOS. So what kind of metabolic follow-up should patients with PCOS get? Well, every 6 months at the start, and thereafter, once the patient is established on treatment, annually, patients should have their weight and their BMI assessed. It's important to ask patients permission in the clinic to talk about their weight, and that's something that we have not done well as clinicians in the past. Some patients will not want to speak about weight for a variety of complex reasons. So most will. So I would encourage you just to seek permission to talk about weight, and then that helps to avoid stigma and it helps to avoid any barriers to the consultation. Every 3 years, a patient should have, at a minimum, a fasting glucose, ideally a HbA1c. Oral glucose tolerance tests are kind of cumbersome, and I reserve those for patients with an abnormal HbA1c. Patients with PCOS and other diabetes risk factors, so that could be a history of gestational diabetes, it could be a family history of diabetes, or it could be in patients who are who have significant overweight or obesity. You should consider doing an OGTT every 1 to 3 years. And all women who have PCOS who are pregnant should have an oral glucose tolerance test for gestational diabetes between 24 and 28 weeks. Blood pressure should be checked annually. 24-hour monitors should be arranged in those with abnormal sporadic readings. We recommend lipid screening in some patients with PCOS. Certainly in the postmenopausal phase, lipids should be measured. In premenopausal years, it is difficult because the interventions that are available are limited, and we usually don't like to give statins to women who are of reproductive age if possible. I would encourage you to consider other atypical health complications of PCOS as well. So screening questions for obstructive sleep apnea should be considered. There's actually a very high prevalence of obstructive sleep apnea in PCOS. It's probably about threefold higher compared to women of the same weight who do not have PCOS. And just be aware of the long-term risk of endometrial cancer. And it's very important to try and induce 4 to 5 menstrual bleeds per year to minimize that risk. There's a lot of data out there now in other studies, direct and indirect, that indicates that women with PCOS are at increased risk of cardiovascular disease and potentially premature mortality. So this was a study in the US on a large cohort of nurses who, over a prospective period of time, submitted questionnaire responses. And what they were able to show is that menstrual cycle irregularity was a big risk factor for premature mortality and cardiovascular disease. And I think all this is not to create alarm or, I suppose, undue panic, but I think what this really represents is it's a surrogate marker for underlying untreated PCOS. And we know that irregular or absent periods, for a variety of reasons, is associated with long-term adverse health outcomes. But you can see that the risk of premature mortality in patients who have generally very irregular periods for many years is about 1.6-fold increased. So it's important that we bear that in mind when we are looking at treatment. And many of these patients would not have had treatment for PCOS in the same way that we are screening and treating our patients now. This is a study I did during my time in Birmingham, where we looked at a large primary care database of patients called the Health Improvement Network, or the THIN database. And basically, this covered about 700 GP practices across the UK and was quite representative of the UK population in general. What we found was that women with PCOS were much more likely to develop non-alcoholic fatty liver disease, even those of a BMI not considered to be elevated. So PCOS women in red with a BMI below 25 still actually had a significantly increased risk of non-alcoholic fatty liver disease. So this is a metabolic manifestation in the liver, typically with steatosis and other issues. And you can see that as the BMI increases, so too does the risk of non-alcoholic fatty liver disease. So that a woman with PCOS whose BMI is above 30 has a really markedly increased risk of non-alcoholic fatty liver disease. And this was the first study to show this in a population in the UK. And what's also interesting is if you look at serum testosterone concentrations, this is probably a risk factor for polycystic, for the development of PCOS-related non-alcoholic fatty liver disease. So once a woman's testosterone concentration was above 3, that greatly increased her risk of developing non-alcoholic fatty liver disease. But just going back to the study from Beaumont, which was an audit that we did a couple of years back, and I showed you referral patterns on an earlier slide. This is more about associated comorbidities, and we're understanding more and more now about associated health risks, whether metabolic or otherwise, and we're understanding more and more about what we should be screening patients for long term. So we were really surprised to see that actually that there's a lot of atypical health complications in this population. Many patients will report dysmenorrhea and menorrhagia, which perhaps isn't surprising, but PCOS is typically associated with absent or infrequent periods. So a lot of them will have menstrual dysfunction. The mental health side of things is really important. A lot of patients will have mood disturbance. This is broadly in line with international figures, somewhere between 15 and 20%. Personally, I think it's probably even higher, and this usually manifests as anxiety and depression. We don't fully understand whether this is simply a secondary phenomenon due to low esteem issues around weight or cosmetic problems, or whether it's a primarily hormonal driven mechanism in the brain. I spoke a little bit about obstructive sleep apnea. This is actually quite a high prevalence when you consider that this is a young population. Non-alcoholic fatty liver disease, dyslipidemia, and hypertension, all present. We don't have a control group to compare to, but certainly this will be far beyond what we would expect in the background population. Screening for psychological aspects of PCOS is actually challenging and difficult, and many of us in the clinic just won't have time to get into it in detail, or we won't feel that we are comfortable in doing it. My team in Beaumont have been collecting questionnaire data like quality of life, so the SF-36, and then the HADS questionnaire for anxiety and depression. And it is really worth collecting this data and validating it. But all the sort of latest studies on mood disturbance and PCOS reach the same conclusion, that there is a significantly increased risk of mental health problems and that we should be screening for it systematically. And we'd love to have psychologists and psychiatrists linked to our clinic, but resources don't allow it, certainly in my institution. So we're going to collect this data and support applications and business plans for psychological support on the basis of the results. But I would encourage you to focus on the mental health aspects of the condition as well. So I'm actually going to finish up on that slide, if that's okay. So just to summarize a few of the key messages, I hope that you have found this beneficial. PCOS is a highly prevalent condition that affects 10% of all women and possibly even more. There are health consequences right across the female lifespan, so this should no longer be considered a disorder primarily of reproductive age women. We know that cardiovascular disease is increased. There is a high metabolic risk. Type 2 diabetes is present in probably an odds ratio of 2 to 3 compared to the background population. And some studies show that it develops about 5 years earlier than it does in the non-PCOS population. We need centralized care pathways. At the moment, patients with PCOS come to us through all number of avenues. And many patients with PCOS will speak of their dissatisfaction with the journey that they've experienced by the time they come to endocrine clinics. So they may have been to see previous endocrinologists, they may have been to see gynecologists. Traditionally, people have been told to, go off and come back when you want to discuss fertility, and not offered metabolic screening and other sort of comorbidity screening like the mental health aspects that I've mentioned. So we need to kind of centralize and standardize what we do for our patients, and the new guidelines have gone some way towards doing that. And I would urge you, just to reiterate my last slide, consider the mental health aspects which have traditionally been neglected in this condition. So with that in mind, that's my final slide, and I'd be very happy to discuss further or to answer any questions that you might have. I'm going to stop sharing, Louise. Is that correct?
Yeah, that'd be great, Mick. So I'm going to move on to the next talk, and then if we take questions after that, is that okay with you?
Sure.
Yep, lovely. Okay, thank you for a great presentation there. It's really informative and raises a lot of questions, I think. We've got a few on waiting for after. So my name's Louise Brendan. I'm an advanced nurse practitioner at Guy's and St Thomas's Hospital, and I would like to disclose I am very much a novice when it comes to PCOS, but having done a little bit of reading prior to today's session and just listening to Mick, it really flags for me that this is an area that perhaps we need to explore a bit further from a nursing point of view in my trust, and I think perhaps across the endocrine nursing realm. So I work at Guy's and St Thomas's. So Guy's Hospital is right by the Shard, and St Thomas's is just opposite the Houses of Parliament. So a great centre to visit if you're interested. So let me just move on to the next one. Oh, sorry. So today I wanted to just do a quick overview of nurse-led services in the UK, and I'll explain why. Secondly, to just overview our competency framework, and thirdly, how we utilise that from a PCOS competency point of view, and then how we can evidence our competency in practice. So, certainly in the UK, we're involved in so many different aspects of care, from endocrine function tests to nurse-led clinics, telephone advice, education, and these are all things that would be well incorporated in a PCOS framework. And if we look at the recent UK nurse survey in endocrinology, we had 174 responses. And you can see that clinical practice is quite high on our list of our job plans and education and teaching. And again, it just highlights that nurses may be well placed in the management of PCOS. When we look at the conditions that are commonly seen across the participants in the survey, about 14 out of 115 nurses who are doing nurse-led services reported they do reproductive or hormonal disorders. And I'm not sure that we can say that that's all PCOS. It's probably to do with other reproductive issues that we have in endocrinology, patients with pituitary pathology, and so on. So again, it's just highlighting that at least 12% of the nurses doing clinics have some input in this area. Currently, the framework covers a number of areas, PCOS being one of them, and we're in the process of updating all of these competencies to include 2 additional elements to this, and I'll explain that in a little bit. And these are the new ones that will be coming: leadership and management, education, research, and this is in line with the advanced practice framework. And we've used this to redefine the competencies there. And when we asked nurses what they're actually doing in the UK, are you using the framework? At least 68% are. And there's a good awareness that it exists. And I think part of the uptake and use of the framework is about how do you really utilize this in practice. I'm hoping I'll be able to give you some pointers today for those who aren't currently using it or aware of it. So when we look at the PCOS framework, and I'm not going to go into detail, but just really to flag up where we look currently in terms of achieving competency in this area. So competent would be in the UK a band 5 level, so a staff nurse level. Proficient would be your kind of deputy staff nurse, senior staff nurse, and expert would be your advanced practitioner, nurse consultant. And a lot of what Mick's talked about today, you know, is evidence within the competency as key things. So, for example, promoting lifestyle changes which positively impact on PCOS symptoms, but also outcomes when we look at the increased cardiovascular risk and other associated comorbidities that we see with PCOS. And again, recognising condition-specific psychological issues and providing support to patients and family and how we do that. So we can come back to this later as needed, but when we're looking at the newer framework, the way it will be set out is that we will have for PCOS the very clinical aspects, you know, the things that we undertake in clinic, and then the more general things across the whole spectrum of endocrine nursing, like leadership and management, education and research, will be separate to this. And again, just highlighting that registered nurses would be in this competent to expert field, and then your healthcare assistants. And I'm not sure outside of the UK if you have roles that you utilise in this manner, but it'll be interesting to hear from you about that. So again, these are the two key things we use in the UK. So we've got the multi-professional framework for advanced clinical practice in England, and that's our 4 pillars. So leadership and management, research, clinical, and education. And generally, there's an expectation that you're working at master's level or above to come under the advanced practitioner title. So when we're using the competency framework, although this isn't necessarily, I think it's important if you've not started a service, but you're looking through the competency framework, and see, well, for PCOS, that could be something we could do. It's really important that you make sure that you've got your management and lead consultants behind you in setting up these services, and there is an identified need, and that it's financially viable, so that the service can be set up and funded appropriately. The next thing I think that's key in regards to looking at your competencies is making sure that you have a mentor or supervisor. And in isolation, there are many nurses that work in isolation in endocrinology. So having somebody to be able to do that for you, it may be a consultant, it may be a doctor. You may also think about outside of your area of practice, somebody that perhaps is a nurse expert in the area that could also act as your mentor supervisor to help sign off your competencies. And at the outset, what you need to think when you're starting with your competencies is a mapping exercise, and really that's to identify for you what your current level of competency is and where your learning needs lie. And that then leads quite nicely into drawing up a learning contract or objectives to achieve what you want to in that area. It might be that you've got a good understanding of the general management of PCOS, that you want to set up your own nurse-led service, and what are the things that you need to achieve that, and also setting a timeline to achieve those. Also identifying resources and opportunities that are going to enhance and develop your knowledge and skills. It might be that you think, well, I've just heard Professor O'Reilly and I'd really like to go visit his centre and, maybe sit in on some clinics. Obviously, funding is something there, but it's thinking about outside of the box what's going to help you to develop your knowledge and skills and be successful in your service delivery. And importantly, it's about making sure that you have a progress review in place. And again, if you're lucky enough to work with a team of nurses, endocrine nurses, then having a progress review with your senior nurses is great. But if you're again working in isolation, that can be a little bit more difficult. So it's important to liaise with your mentor supervisor as to what is going to be the best way for you to have a progress review and have your competency signed off. And when we're thinking about how do we evidence our competencies, there's so many different ways we can do that. So you might do a presentation about diagnosis and assessment of PCOS. You might do a presentation on setting up a nurse-led service and why it's important and in this population, and what you need to support that service, and what training that you've done and you've completed, why you've done that, and all the supporting tools that you have for the service. Written documentation, that could be your clinical review, so your outline of your assessment, history taking, diagnosis, and management. So direct observation, sitting in on clinics and reflecting on what you've learned in that clinic, how you've adjusted your learning and your assessment tools. reflective practice. I'll talk a little bit more about that, but that's something that we all do within our practice. And it might be that you've attended a conference and you want to demonstrate what you've learned. The webinar today is a great opportunity to do a bit of reflective practice on what you've learned, where your learning needs are. And if for me, for example, today, it would be about, furthering my knowledge and skills and thinking about the provision of a nurse-led service, and is that something that would be viable in our area. So thinking more about the strategic and service development side of it. You can also, obviously, as I said, about courses and conferences. The webinar today, again, is a great opportunity to evidence how you have developed yourself in this area. Your teaching, so it might be you do a teaching session, educating your patients, so actively being reviewed, doing those things. You might have a publication, an abstract about your work, what you've, for instance, if you set up a nurse-led clinic and satisfaction regarding that, so supporting and looking at the psychological impact of PCOS and what's happened with the doing a before and after of the service, for example. And then any contribution to service delivery that you have. So that may be audit, it might be research, it might be setting up a nurse-led clinic. So these are all examples of how you can evidence your competency. And importantly, it's about supervision and practice as well. So discussing your cases, checking that your assessment and management is appropriate, that you might do work alongside a consultant where you're seeing the patient and do your assessment, then bring your consultant in, say, and with the patient there, go through, this is what we've talked about today, these are our strategies, this is my plan, these are the assessments I've planned, this is the referrals that are required at this stage, and so on. And again, just kind of reiterating about reflective accounts. So you could use a nurse-led setup, for example, and within that discuss the knowledge and skills and the assessment and diagnosis of PCOS, and more in depth, for example, why you're doing the investigations you're using, why you use the tools you're using, why it's important to do, assessment in terms of quality of life and heart, cardiovascular risk factors and so on. And again, practice related feedback is really important. You can get verbal or written feedback. Again, that could be when you've done a piece of supervisory work where you've been supervised undertaking a review and having that documented. And I've borrowed this off Lisa, so I'm sure she won't mind. Lisa Shepherd, who I'm sure plenty of you know. Oh, sorry, wrong way. And I think importantly, the other thing that we need to think about is how doctors and our management teams can support endocrine nurses in training and developing in this area. And just before I go on to that, I am going to go back to the competency framework for PCOS and just talk a little bit about that again. So our seniors can help us, or our more experienced doctors, nurses in this area may have frameworks already or protocols or standing operating procedures or templates for clinical assessment to help guide you and ensure that you are assessing and completing all the required assessments at review. And if those aren't there, then supporting you to develop those. Again, being signposted to any relevant training, research, or academic courses and networks. Mentorship within your own team, or if you've not got an expert, going to an outside source if you're, for instance, working in isolation. And encourage by encouraging and mentoring nurses in audit and research and governance. Again, organizational support, so for administration, in our clinics, teaching, clinical supervision and management, and funding, importantly, to attend the relevant courses that we should be doing to achieve our competencies. Again, just admin support, making sure that nurses are actively involved in the team activities, so post-clinic meetings to discuss cases, MDTs, journal clubs, and just having a detailed job plan in regards to the service that you're running. And then just pulling out the resources that support in practice. So in the UK, we have the NICE guidelines for PCOS, but importantly, we have the updated international evidence-based guideline. Our professional bodies, so ESE, the Society for Endocrinology, find any conferences they're running, training, webinars, the mentorship. We have the online platform with Cooper that can link you to somebody that's specialist in that area if you're working in isolation, and obviously the competency framework for highlighting the key things that you need to be signed off on. Patient support groups are a huge support for both clinicians and patients. So Verity is one that we use in the UK. Other patient support groups like Diabetes UK and Heart UK have a wealth of information. In Heart UK, if you're looking at wanting to know a little bit more about hyperlipidemia and cardiovascular risk factors, have excellent modules that you can do that are free and just help, encourage your learning there. Other online resources that we can use, Endotext for drug queries. In the UK, we use the Electronic Medicine Compendium, and the NHS. So again, looking at local kind of or national health information. So the NHS, for example, has information on smoking cessation. If you want to sleep apnea, there are so many resources within there that are validated and useful, and then the knowledge and skills summaries and that NICE also provide. Networks, you may have local nurse networks set up in your country. So again, just tapping into those and seeing if you can meet and look at other nurses' frameworks that they have in place for doing this kind of clinic. And again, just reiterating in-clinic training with either your local team or other specialist centres. We also have information available to us via our professional bodies. In the UK, that's CNMC and RCN. And also we have some excellent recognised textbooks from an endocrine point of view with the Advanced Practice and Endocrinology books and the Oxford Handbook of Endocrinology and Diabetes. So they're great resources there. So that's really it from me. So short and sweet, but just coming back, I'm just going to come back to the competency document. So what we tend to do when we are evidencing what we do is take one of the strands and then use any of those evidence resources to highlight how we have achieved that and then get it signed off. So it's not just a matter of a tick box exercise. You really do need to demonstrate your learning and how you've achieved that outcome and give examples. So that's it from me. So I think we will go back to, I'm going to stop sharing, hopefully. Let me just go back. So if I can just get someone to confirm I've stopped sharing my screen because it's disappeared on me. Hopefully I have. Yeah.
Louise, you're still sharing Epic.
Oh, Epic. Oh, that my screenshot. Okay. So I'm just going to come back to, I'll stop share. Sorry, that's simple. Okay, so yeah, so mine was very short and sweet. So I think we've got a really nice uh, uh, amount of time really for our questions. So I'm just going to go into the Q&As, and I'll be just saying your name and what your question is, and I'm going to go right back to the beginning. So great. So this is from Cosmina. Can letrozole be prescribed by GP? Uh, so,
Want me
Mick,
to
if you,
answer that,
yes,
Louise?
yes, please, Mick. I'm not sure in other countries, but
Yeah,
yeah,
it probably depends on what country you practice in. I know from working across both jurisdictions of Ireland and the UK, it would almost never be prescribed in primary care. Some GPs would have concerns about maybe risk of multiple pregnancy. I think really it should be prescribed in a secondary care setting. That would be my view. And that's what happens certainly in Ireland and the UK.
great. Thanks. Um, okay, so the next question is from Shihu Tia. We've got two questions. Apologies if I've got your name around the wrong way. So the first question is, when a patient has PCOS based on the Rotterdam criteria, but slightly twofold increment of prolactin, and on MRI has a small microadenoma, but we don't know for sure if it's microprolactinoma or as even PCOS can increase prolactin, FSH and LH, and normal follicular phase range. Do you start with cabergoline or COC?
Yeah, that's a tricky one, and it comes up all the time, unfortunately. So there is a bit of hyperprolactinemia in PCOS, whether that's from androgen excess or a bit of anxiety, etc. It's often hard to say, but we will usually, uh, if the prolactin is elevated in a meaningful way, so I would certainly repeat it if it's elevated once, and if it remains elevated, I think scanning the pituitary is the right thing to do. Um, Again, with normal estradiol levels that are not suppressed and a prolactin below 1,000, it is unlikely that that's relevant hyperprolactinemia that's contributing to their menstrual irregularity. Sometimes we'll give metformin and we see what happens. Will that regulate the cycle? Once you give the pill, you don't really know what's happening because you've kind of bypassed the effect of the prolactin and the PCOS. So I tend to give metformin if they're kind of overweight obese to regulate the cycles. And then if that doesn't work, sometimes it's trial and error and you go back then and prescribe cabergoline. So it's a tricky one, comes up a lot.
Hey, thanks, Mick. So the next question again um, from Tia Shehu. What method do you use for assessment of thrombosis risk before starting COC?
So really it's just a couple of screening questions. There aren't any, validated tools that I'm aware of that would absolutely identify a patient at increased risk. But I would ask about family history of thrombosis. I would ask about blood clots, personal history, obviously, and in patients who are above the age of 35 and who are above with a BMI above 30, they will be immediately at an increased risk from going on the pill. If they don't meet any of those parameters, the risk is really very low, to be honest. And although the pill increased the risk 4 to 5 fold, the absolute risk is actually very low. So if they're not overweight and don't have a family history and don't smoke, generally I'm relaxed about it.
Great, thanks. And we've got another a question from Gabriella Madaras. Can I give COCP to a teenager with acne? She is 15, menarche at 12, referred to me by the dermatologist. We've got another of our participants today, Jackie O'Sullivan, who's replied, definitely something done at our centre, GNCH in Newcastle. Some GPs very happy to prescribe following endocrine advice. Did you have anything further to add, Mick?
Yeah, I would agree with that. I think very often the pediatricians will prescribe. Increasingly, the GPs are doing it and they may not even seek endocrine advice. If there's acne, it's clearly hormonal acne. And even if they don't have other features of PCOS, it's often reasonable to try. So I don't see patients in this age group, but anyone above the age of 16, I'd have no hesitation. That's the youngest that I see. And I know that my colleagues in pediatrics prescribe it quite a bit, so be safe.
Great, thank you. And another question, how long would you treat with COC? That's Tia Shua from earlier.
Yeah, there's no absolute endpoint to that. There's no right or wrong length. Some people are on it for years and years, and you've got concern. Some people get very worried about post-pill amenorrhea. That's actually quite a rare phenomenon, despite what we hear, anecdotally. It's post-pill amenorrhea is only 1 or 2% of patients on the combined pill. Certainly, anybody who's heading into their mid-30s and they're still on the pill, I would be thinking about trying to take them off it from the age of 35 on. It's often good to have maybe after 3-4 years in younger patients, let them have a washout from it from a month or two, or for a year or two rather. But you have to be careful then that they don't conceive, because they'll come back and express dissatisfaction if they hadn't an unplanned pregnancy. So no sort of right or wrong answer, no absolute endpoint to when they should get it.
Okay, so next question from Gabriella. How do you treat a woman with recurrent big ovarian cysts, 5 to 6 to 7 centimeters, with no menstrual irregularities and normal weight, no other comorbidities associated, no other chronic diseases?
I would send those patients to gynecology. Those patients that are not likely to have PCOS. Remember, it's important to say to our patients, often they will report, well, I've got multiple cysts, or I've had surgery for cysts. Most patients with PCOS, the name is a misnomer. They've got multiple little follicles on the surface of the ovaries, big cystic lesions in patients with regular periods without other features of PCOS. They should be managed by the gynecologist. The pill can help, but I would refer to gynecology.
Okay, thanks. So we've got a comment from Cosmina, just reiterating mental health is a very important aspect, speaking from experience. And next question from Rana Al Musa. Rana has a few questions. So how can we suspect PCOS in a postmenopausal female, as we cannot judge on menstrual irregularities?
Yeah, that's tricky. And most women with PCOS, it's a retrospective diagnosis if they're postmenopausal. So they will tell you, for example, that they had very irregular periods during their reproductive years, that they had difficulties conceiving, or that they had, hirsutism that was untreated or ignored for many years. So you're right, it's a retrospective diagnosis.
Great. And next question from Anna again. Could you please explain the utility of day 21 progesterone in PCOS?
So that's a test to evaluate ovulation, and ovulation will be associated with the progesterone level on day 21 that is in the ovulatory range. So if ovulation takes place in most cycles around days 14, 15, the mid-luteal phase is around day 21. If ovulation has taken place, progesterone increases in the blood and peaks around day 21. So if you have a progesterone of above 20 or 30 nanomoles per liter, that means that the patient ovulated that month.
Okay. And final question from Rana is, how do COCPs reduce the risk of endometrial cancer and PCOS, while in other studies they increase the risk?
The majority of studies would show that combined estrogen preparations reduce the risk. The vast majority of studies would suggest that anything that increases cycle regularity from irregular to regular will reduce the risk of endometrial cancer.
And from Paulina, if Betsy, if someone has acne, irregular menstrual cycle, intense hair growth, normal ultrasound, and normal hormonal tests, has she PCOS?
The answer is yes. So that patient meets 2 out of 3 Rotterdam criteria and therefore has a diagnosis of PCOS. So acne and hirsutism ticks the androgen excess box. Irregular menses ticks the oligomenorrhea box. Regardless of the ultrasound, you do not even need to do an ultrasound on that patient. They absolutely have PCOS.
Lovely. And then we've got a question from Kelly Pendle. What would be your recommendation for next line treatment when COCP contraindicated (migraine with aura) and MTF not tolerated? Androgen query. Sorry, I'm not sure if that where the query. Sorry. Androgen excess is the main issue. Fertility not desired, and contraception not an issue. Husband has had a vasectomy, no menstrual irregularities, and the BMI is normal.
Yes, that's a good question. Comes up a lot in clinical practice. So the pill is contraindicated. It's worth remembering metformin is good at restoring menstrual cycles, and it might actually lower the testosterone level in the blood, but it's not a very good treatment for androgen excess. It's not effective at all. So it's not going to help. In this case, she's got clinical signs of androgen excess. I would give her spironolactone, and she doesn't need to worry about getting pregnant because her partner's had a vasectomy. So you can just document that in your notes, say that you are re-emphasizing that patient should not conceive on this medication, and you are reassured that her husband has had a vasectomy, and then you've done your bit.
Great. And I have a question, if you don't mind.
Yeah.
So I'm just wondering, do patients ever do kind of this, obviously when you're asking them to do the, I'm just going back to the Ferriman-Galway score, and, some, may have issue with the examination. Do you ever get them to circle which they think is more close? Is that helpful at all? And
yeah, sometimes we ask them to do it to mark it on the basis of their worst day of the month, for example, when they haven't removed their hair. So you can do that. Sometimes you see the clinician will actually mark it with the patient, but you're right, that's a situation where you ask the patient to mark it themselves.
And in regards to saving a bit of time, do you think doing preclinical, the patients doing questionnaires before they attend the clinic, like the HAD score, or for psychological well-being, is something that's advantageous? So on the day you can kind of focus on the key.
Exactly. Absolutely. It saves time. Any kind of clinical information gathering that can be done remotely or in advance of the consultation makes the consultation more effective. There's a bit of an administrative burden to getting it.
Yeah.
But if you can do it, it really makes the consultations more productive and fruitful.
Yeah. Okay, so we've got another question from a few more questions that we'll finish up with. So Rana Al-Musa has asked, doesn't progesterone increase weight? Wouldn't that be troublesome for PCOS patients? Any preferable progestin to be selected? Many thanks.
So if you were giving the combined pill to a patient, the doses of progesterone in that are very low. And if I was picking a combined pill, I would pick one with an anti-androgenic progestin like drospirenone. So that's preparations like Yaz or Yasminel or Yasmin. If you're giving progesterone monotherapy, that's drugs like Cerazette or Azalea, which contain desogestrel. In most people, that's not associated with meaningful weight gain. The other way that we give progesterone is sometimes in a cyclical way, once for a week, every 3 months to an amenorrheic patient that will induce bleeding. They won't see any of the adverse effects of progestogenic side effects or anything like that if you're giving it in a cyclical manner like that rather than on a daily basis. Most people have no problems with low dose progesterone.
Right. And then one more question from Frankie Van Beveren. Can you have adenomyosis and PCOS in the same patient, given they may be considered opposite issues, and how do you treat?
Yeah, it's more a question for the gynecologist, but we often see endometriosis, adenomyosis, PCOS, and all sorts of issues in the same patient. So I would manage their PCOS related issues, whether it's menstrual dysfunction. If they've got clinically meaningful adenomyosis, they need to be linked in with gynecology. And I do a joint clinic with my gynecologist, mainly focusing on fertility. But sometimes things like this come up and we manage them together. So good communication with your gynecologist.
Okay. And then one more question from Rana Al Musa. Do you prescribe metformin for normal weight? I think in PCOS, I think.
You could, you can. I would say could rather than should. The latest guidelines suggest that you can prescribe metformin to lean patients in selected cases. So we do it quite regularly, particularly if somebody was trying to conceive, they had irregular periods, clear PCOS, I would give them metformin. You don't want somebody who's on the cusp of being underweight to lose any more weight on metformin, but usually that doesn't happen. But yes, you can.
Great. So I think that's all the questions that we have for today. So just a couple of thank yous from Alison Milne, Frankie Van Beveren, Cosmina. So I want to thank you all so much for joining us today, and especially Mick, for your time today. It's just been a really great session. I've learned a lot, and I need to facilitate a bit more learning, I think, when it comes to PCOS. But thanks again.
And thanks, Louise, for the invite. I really enjoyed it.
Thank you very much. Thank you, Nick. And thanks, Louise.
Oh, you're welcome.